Top Med Talk.
Welcome to Top Med Talk. This piece has been supported by an unrestricted educational grant from bioMérieux.
Hello everybody, my name's Andy Shaw. I'm an anaesthesiologist intensivist at the Cleveland Clinic in Cleveland, Ohio. Today I'm going to talk about biomarkers of acute kidney injury and ask the question, how useful are they really? Here are my disclosures for 2021. None of these have relevance for the subject of today's talk. I'm going to ask ourselves 4 questions. Firstly, what is a biomarker? Secondly, what's wrong with serum creatinine, the biomarker we all use every day? 3, where will we find new biomarkers? What pathophysiological processes will they originate from? And then finally, how can we use them in our practice? And is there any evidence published that suggests that they may in fact be useful at all? The NIH defines a biomarker as a characteristic that is objectively measured and evaluated as an indicator of normal biology or a pathologic process or a pharmacologic response to a therapeutic intervention. The FDA is a little more succinct. They talk about any measurable diagnostic indicator that is used to assess the risk or the presence of a disease. In terms of evolution of disease states, if we consider the case of acute myocardial infarction over the last 70 years, we can see that the biomarkers we use to detect an MI have evolved to the point where now they're almost too sensitive. The ultra-high sensitivity troponin assays that we use today to measure myocardial dysfunction and damage are significantly more specific and sensitive than the good old-fashioned white count that we used to use back in the 50s. For poor old acute kidney injury, however, we're still using change in serum creatinine just like we were in the 50s, 60s, 70s, 80s, 90s, and early 2000s. Clearly, there must be room for improvement. We've said that creatinine isn't really a very good biomarker, especially for diagnosing kidney injury. It's a marker, as you know, or a surrogate marker of glomerular filtration rate, not of actual kidney damage. And there can be up to a 48-hour delay after the insult itself occurs before the serum creatinine level rises. And during that delay in diagnosis, there's often ongoing damage to the kidney. And that delay in diagnosis prevents us intervening in a timely fashion. However, we're not going to throw away an old friend. Serum creatinine does measure renal function, even if it is a little clumsy. There's a huge installed user base. There's an enormous existing database of how it performs. Almost all of the epidemiology for AKI uses either changes in serum creatinine or urine output. It's very inexpensive, and perhaps more important than any of this, it is available to lower and middle income countries as well. And I think that's really important as we think about advancing the field to make sure that those of us who work in less privileged circumstances are also able to benefit from and contribute to the dialogue. So in 2021, we have perhaps a situation vacant for a new biomarker. So moving beyond serum creatinine, can we measure kidney injury as well as declining kidney function? Are there early or late biomarkers of declining function and or damage that we can differentiate? Are there different subtypes of acute kidney injury? Acute kidney injury is a syndrome, a constellation of changes. But are there different subtypes, perhaps according to the cause of the reduction in renal function? Perhaps most usefully, can we identify who is going to need dialysis and who might dodge it? The answer to all of these questions is yes, we can. Consider the spectrum of kidney injury on the normal situation, progressing through an ever-increasing or worsening severity of illness through simple increased risk of damage to frank actual damage that then manifests as a reduction in GFR to the clinical state that we call kidney failure. And if we fail to intervene with renal replacement therapy, ultimately death of the organism and the organ. The pathophysiology of acute kidney injury was very nicely articulated in this paper almost 15 years ago now by Bruce Molitoris' group. He points out that there is a spectrum and a time course of injury existing from the pre-renal phase, where the predominant pathophysiological process is just simple vasomotor nephropathy without too much of a reduction in GFR, all the way through initiation, extension, maintenance, and then repair phases, And these boxes describe different cellular responses ranging from depletion of ATP in both endothelium and epithelium through microvascular injury, and then ultimately migration and proliferation of reparative stem cells that then redifferentiate and repolarize. Most of the time, however, the patient's GFR doesn't recover to a full 100% of its pre-injury status. And that renal functional reserve, or that amount of GFR that is left in the tank, if you will, would be very nice to measure. But of course, as of today, we can't do that. One concept I think is very helpful when considering biomarkers of AKI is this idea that we may be able to measure function and damage, not necessarily with the same marker. This graphic in Nature Reviews Nephrology from Prasad Devarajan in Cincinnati's group, I think is extremely helpful. It plots on the x-axis increasing levels of dysfunction, and on the y-axis from the bottom of the screen to the top, increasingly severe injury, such that in this graph on the bottom left, the normal kidney, and then we have a situation on the bottom right where there is an increasingly dysfunctional kidney, but may not be manifesting frank, detectable pathological change. An example of that might be volume depletion or overdiuresis. In the top left-hand corner, we see a situation where there is frank injury, but perhaps without manifest reduction in function. An example of that might be subclinical acute kidney injury from mild toxin ingestion. And then we have frank acute renal failure in the top right, where there is both significant injury and a significant decline in function. This conceptual framework, I think, is helpful as we consider the etiology and the pathogenesis of acute kidney injury. If not creatinine, then, where will these markers come from? Here's a very nice summary review of the situation in cardiac surgery. And this group from China talk about biomarkers of inflammation, biomarkers of cardiac function. In particular, pay attention to NT-proBNP. There's some very interesting data coming out suggesting that preoperative levels of NT-proBNP may be highly predictive of who will develop acute kidney injury. The more obvious renal tubule-associated biomarkers such as NGAL and MMP7 are well known. Perhaps the best developed is the combination of TIMP2 and IGF-BP7, which is marketed as NephroCheck. And I'm going to talk a little bit about some practical applications of that test in a minute. I think it's important to remember that it's not just measurable analytes that represent biomarkers. Imaging as well, portal blood flow. There's a huge explosion in imaging renal veins and renal vasculature going on in the critical care world at the moment, as you all know. And I think that we'll have more to see and learn about that as this space unfolds. So a couple of years ago, when I was still at Vanderbilt, we decided to study the time frame of elution of TIMP2 and IGF-BP7 in the context of the cardiac surgical operating room. We measured TIMP2 IGF-BP7 in patients who had previously been enrolled in a randomized controlled trial of statin therapy as a mitigating agent for AKI. And in this picture, you can see we demonstrated that although there is a detectable rise in TIMP2 IGF-BP7 immediately after bypass or the last anastomosis in the case of off-pump surgery, in the operating room still, the peak doesn't occur till postoperative day 1. And a very innovative group led by Dan Engelman at Bay State noticed this in our paper and decided to study whether or not measuring TIMP2 IGF-BP7 on the first postoperative day in all comers would have a meaningful and detectable effect on the incidence of moderate and severe AKI. And so what they did was measure TIMP2 IGF-BP7 in everybody on post-op day 1 at 05:30 hours. And they divided patients into negative, moderate, and high risk. And then they activated the AKI response team in their institution for those patients who'd had a demonstrably high level of TIMP2 IGF-BP7. And you can see on the right-hand side of this screen, they reduced the incidence of moderate and severe AKI from 2.4% to almost nothing, an 89% relative reduction, which was statistically significant at the 0.01 level. And I would suggest, therefore, that this is the first demonstration that measuring a novel biomarker to identify risk in a perioperative population actually does translate into a reduction in clinically significant outcomes. So to summarize then, in this brief introduction or summary of biomarkers of AKI, the diagnostic approach to acute kidney injury is clearly changing as these new biomarkers become available. I like urinary diagnostics because of their proximity to the disease space. They are, of course, concentrated in the urine instead of being diluted in the plasma. And the ease of access for testing is another extremely attractive feature of them. I do like this function damage paradigm as a way to think about and discuss and consider novel biomarkers of acute kidney injury. And I hope I've persuaded you that Dan's group at Bay State have demonstrated that biomarkers are capable of making a clinically important difference in real-world settings. Thank you very much for listening to me today. Please do get in touch if you have anything to ask or even just to have a discussion about acute kidney injury in general.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.